Hey, I want to jump on here real quick and share some interesting cases from this week that I saw, evals that I did. And I get a lot of questions from people saying, well, what about neuro? Does 180 work with neuro? So what I always say is you need to understand that non-contact ACLs are neuro patients, plantar fasciitis, neuro patients, tension headache, neuro patients, impingement, neuro patients. Everybody that walks into your clinic is a neuro patient if you understand the progression to injury, and if you understand that the root cause of what starts everything in the progression to injury is neuromuscular dysfunction. So this week, to prove my point that you can treat anybody, anything, I had an adult severe CP patient, had a 12-year-old patient that was diagnosed at Children's Hospital with CRPS, had another patient that was diagnosed with, they didn't even know. They thought it was shingles, wasn't shingles. So here's what I did with them. And this proves to you that all we're treating with the 180 system is neuromuscular. And even if it is nerve pain, chronic pain, this patient with the CRPS, patients with strokes, this patient with CP, it works to get them down. So the patient with the CP, it gets them down to the original insult. So if you've got somebody with a stroke and the stroke affected certain muscles, primary effect, those muscles aren't going to work. They're going to have to figure out how to compensate for those muscles. They're going to have secondary compensators, tertiary compensators, and this snowball takes effect. And then they have chronic pain because they're constantly compensating. So I don't use a different thought process with a CP patient than I use with an idiopathic low back pain patient. It's the exact same, and here's why. So let's take the CP patient. So 28 years old, CP, had another procedure a couple of years ago to try to decrease the severity of the CP. They did kind of a resection of the corpus callosum, and she actually got worse. So she is actually pretty functional, can walk. Her problem is that she, as the day goes on, just folds in half because gravity is just pulling her forward. She's sitting in a chair, she's sitting on a couch, and she can't fight gravity anymore. So fortunately for her, she has caretakers that have her lay down 3 to 4 times a day, just lay supine and let her relax so gravity isn't picking on her. It's like, okay, well, here's what we need to work on. We need to figure out what's going on with all those extensors that are getting fatigued all day long as gravity is picking on her. So fortunately, she can lay supine, so put her supine on the table and start working with scapular retractors, cervical stabilizers, even pecs, abs, glutes, start working on that stuff. And what do you know, as we're asking her questions, does that feel like that's easier to move? Does that feel like you have more range of motion? All that kind of stuff. And you can actually see that her shoulder passive range of motion went from like 100 to 120 to full. From abduction at 90 to abduction at 120 to abduction at 150. I didn't stretch her, I didn't massage her, because that's what her caretakers have been doing with her, because that's the conventional thought process. So I told them, we can no longer stretch her. We cannot allow her to roll out. We cannot give her a massage anymore. We are going to exercise, and that is it. So by the time we got done with her visit, she had full active range of motion in the shoulder. The other arm is extremely spastic. So we got a little bit there. I wasn't too worried about that. I want to get this going. I want to work on getting her to maintain an upright posture, to get her head upright. So we focused a lot on cervical stabes, scapular stabes, thoracic stabes to get her to pull up into normal posture. So what do you know, when we stand or sit her up, she's sitting up at the table versus being hunched over. We ask her how that feels. She's laughing and giving us a thumbs up. That feels way better. And when she gets up, she can actually move better and maintain that posture. So now, is that going to hold very long? Probably not. So what we're doing is a lot of patient education for her parents and primarily for the caretakers, so they know we're going to get her on the table at home 4 times a day. She's got specific isometrics that she's going to work on for the cervical stabes, thoracic stabes, scapular stabes. There's certain active range of motion exercises that she's going to go through there laying down, then she's going to do them sitting up, she's going to do them standing up. And she's going to do this constantly throughout the day because she has to remind those muscles to stay on. So that's how we treated a CP patient. Now let's go to this 12-year-old who was diagnosed with CRPS, so chronic pain, regional chronic regional pain syndrome, CRPS. Went to Children's. Onset was from a hard throw in softball, and it originated at her elbow bicep area. By the time she went to home and went to bed that night, she had chronic pain throughout her scapula, throughout her delts, into her biceps and triceps. Next day, all the way down into her forearm. So parents take her to Children's, emergency visit. They diagnose her with CRPS and say, there's nothing to do for it.